digital psychiatry, giving you an overview of it. And I have nothing to disclose. So we live already in a digital society where there are more phones than people, and billions of emails are sent every day. There are more than 6,000 tweets per second, some at this Congress, I hope. More than 100 million Alexas were sold already, which illustrates how technology is everywhere beyond healthcare. So digital mental health has the potential to revolutionize mental health care, and in recent years there's been an explosion of interest in and research on the use of technology and mental health. And this focus ranges from the prediction of future illnesses, early detection of illnesses, assessment of illness level, but also improving access to treatment. And today I'm going to be giving an overview of how technology has been used, as well as its potential future pathways for clinical practice and research, which ranges from the use of telehealth, electronic health records, electronic prescription, smartphone apps and sensors, robots, VR, and AI. So starting in telehealth. Telehealth involves the use of telecommunications to deliver healthcare outside of traditional healthcare facilities. And it is seen as the most basic element of e-health, which uses a wide range of information and communication technologies like text messages, video, and audio calls. And for example, in the UK, the NHS offers the GP at hand, which provides access to a GP 24/7. So in other countries, there are similar initiatives, for example, of online therapy. And in the States, there is an app called Talkspace, which allows people to have access to a licensed therapist online by writing asynchronous messages. And their package is called Unlimited Messaging Therapy, and it comes with a slogan that emotions can't be scheduled. And it offers people the opportunity to message a personal therapist with whom they are matched with whenever they want. And it has already thousands of therapists registered from across the country. Another important use of technology are the electronic health records, and this will possibly lead us to have real-time patient data, which the care teams have access to with dashboards that link primary, secondary, and social care data to produce an integrated care for patients. And yet, moving towards these complex data collection systems in a health information ecosystem poses questions about the different users that can have access to this data and will be able to modify it. For example, would the electronic records be retrieved by health, social, and justice authorities as well as patients? And what if there are disagreements about the content of the joint history data? What would be the mechanisms that would or would not allow for modifications? Or maybe like a more provocative question, with all this data in the future would be perhaps publicly available anyway, disappearing the notion of privacy and confidentiality in healthcare. So some food for thought for reflection. Another valuable use of technology is the prescription without paper, where the medication prescribed can be collected in the pharmacy directly, and the cross-border e-prescription is working already, for example, between Finland and Estonia, with Finnish patients being able to go to a pharmacy in Estonia and retrieve medicine prescribed electronically by their doctor in Finland. And at least other 8 EU countries are expected to greenline these exchanges soon. So although the EU member states have different data protection and confidentiality laws, which many had perceived as barriers to such initiatives, it has been possible to put in place such a help fund and collaborative project across countries. So another use of technology are sensors, which are devices whose purpose is to detect events. And in November 2017 in the States, the Food and Drug Administration has approved the first sensor pill, Abilify MySight, which is an antipsychotic, the aripiprazole. And this oral tablet is embedded with an ingestible sensor that allows patients and, if given access, doctors and caregivers to track the medication ingested on a smartphone or computer. And the system sends a message from the pill's sensor to a wearable patch on the patient, which then transmits to the device. Then apps, smartphone apps. There are an increasing number of smartphone apps for different purposes, and mental health is no exception. And in the UK, we have the NHS Apps Library, which aims to help patients and the public to find health and well-being apps that meet the standards of NHS Digital. But what is interesting is that a recent article published in the Nature Digital Medicine on the evaluation of mental health apps asked whether we are using science to sell apps. And they found that of the 733 apps they evaluated, they noted that only 10 apps had live experience involvement, 14 apps had some element of wisdom of the crowd, and 23 apps had some sort of technical expertise. So there were no apps referring, for example, quality development or assessment or any type of app certification. So John Torres recently presented the APA app evaluation model, and the four main areas covered besides gathering basic background information are safety and privacy, evidence, ease of use, and interoperability. However, since apps are constantly updating and changing, this could mean, for example, that these evaluations can be quickly outdated. And also another aspect is, for example, determining the usability can be actually quite subjective and depends on how each patient experiences and feels after using it. So there are some food for thought and reflection about this model. Then robots. Robots have also been increasing in mental health, mostly to develop treatments to children with autism or older adults with dementia. And robots can vary in appearance, from very mechanical looking to very anthropomorphic. Humanoid robots have been criticized for giving inaccurate expectations about a robot's capabilities, with some arguing to be unethical to use when treating vulnerable populations. And in this first picture on the left, we have the EU-funded Mario project, which was developed to be a companion to reduce loneliness and isolation in people with dementia. On the other hand, many people have a latent fear of non-humanoid robots, perhaps due to science fiction movies in the 60s, like the Daleks in Doctor Who. While for pets, the pet robot Paro, I'm not sure if you can see it with my video camera on top, but the robot, which is a seal, has been used in care homes as a substitute for physical animal therapy, reducing loneliness. And interestingly, even some pilot research found a decrease in blood pressure when participants had Paro and an increase of blood pressure when the robot was withdrawn. And this leads actually to many important questions. So for example, Google has obtained a patent on robot personalities. And what will happen if the robot is programmed to take on the personality of real world people, like a celebrity or someone that died already? Would this be a door to have humanoids living forever and in several places? And also, which service skills and personalities in place robots could perhaps replace many customer services, taking over many human staff positions once robots are cheaper and more efficient. So that's another controversial and food for thought. Another example, which has been quite debated, was the citizenship that Saudi Arabia gave to the social humanoid robot Sophia. And by having citizenship, would she be able to vote or get married? So these are other interesting questions that we can reflect. Virtual reality has increasingly entered our lives with headsets that can be used with our phones. And in mental health, VR allows to recreate the scenarios in which the psychological difficulties occur. For example, exposing the person to the environment of a packed tube, as you can see in the picture, that triggers the phobia, or cue exposure triggering the cravings associated with their alcohol abuse and smoking. And VR is also being used in domestic violence offenders, making them experience a virtual scene of abuse themselves through immersive VR in a virtual body of a woman. And there is an article that was published that shows that they saw a virtual man who displayed violent behavior towards them. So if they were speaking, they would be shouted, "Shut up." And if they were looking elsewhere, they would be shouted, "Look at me." And this research, which was done in Barcelona, has showed that changing the offender's perspective improved their ability to recognize fear, improving their empathy. So this is quite interesting and worth reflecting. Also, research done with veterans with PTSD in the States even included a virtual therapist, and it showed that veterans were more likely to reveal information to virtual coaches, actually, than the face-to-face therapists. So virtual coaches can respond predictably and efficaciously, never fatigue, and are not subject to transference or countertransference reactions that can compromise communication. Artificial intelligence is also much potential in mental health care, although the field of AI is not new, as you can see in this picture. And there is now an increasing awareness of it, as illustrated, for example, by this increasing number of Google searches on AI, ML throughout time. So artificial intelligence, just for clarity, is the overarching term and is the human intelligence exhibited by machines. And then machine learning is an approach to achieve AI, a technique that enables machines to learn tasks with experience. And then deep learning are the algorithms that permit the software to train itself to perform tasks. And sometimes these terms are used interchangeably, but they mean actually different things. So in 2017, it has been estimated that AI will probably impact the most in healthcare, enabling more precision and efficiency with significant cost savings. And with surgeries, for example, being done by assisted robots, using virtual nursing assistances, monitoring patients' symptoms and behaviors, diminishing visits to patients, but also with the integration of AI in admin work, for example, reducing dosage errors and improving the detection of fraud. It has actually been predicted that the future of AI would enable different developments across time. And first, it would help with improvements of the perception of the world. And then it would move to developing cognition, building relationships, and by 2036, actually filling our roles. So in terms of the perceived world and monitoring behavior, there are t-shirts already that monitor our heart rate, breathing, and movements, as also do fitness tracking devices, and biosensing tattoos whose colors change when your blood sugar levels change, which is helpful for people with diabetes. Cars that detect alcohol levels and are instructed to stop if the driver is drunk by sniffing a driver's breath or scanning the blood in their fingertips through the steering wheel. Maybe it hurts a bit. Yet all these devices may pose actually important concerns. So for example, in 2018, a fitness tracking app, Strava, gave away the location of secret USA Army bases through the geolocation data, actually pinpointing overseas facilities. So all these innovations are sometimes worth considering the implications they may bring. So moving on to speech, which can be collected passively and can be quite rich. Sound Health created an app to elicit and collect speech samples along with questionnaires, and data were collected from general population sample in the States, where participants completed several voice tasks on their personal smartphones on uncontrolled natural environments. And as you can see in this graph, there was a decreased speakers that had difficulty in producing more energetic, so aroused or happier, more positive valence speech than non-depressed speakers. And also they used words and phrases that take less effort and have less articulatory precision. Facial analysis is also promising in this multimodal framework to help with diagnosis and monitoring and looking at facial and head motion, exploring, for example, smile duration and intensity. And research using body movement analysis showed that lower Hamilton rating scale scores were linked with higher movement activity. So overall, using technology in the clinical and research settings involves a large number of important things to consider, and these are actually key and with important consequences. So not only they are important, discussions and reflections and considerations, but also planning beforehand to ensure that once they are launched, they are done so in a proper way. So quite important are, of course, patients' preferences. And in my research, I've been looking at whether patients prefer face-to-face or digital interactions when speaking with a volunteer. And we found that younger patients were more interested in technology, and those with lower quality of life were more interested in face-to-face contacts. Also, the expectations of these interactions varied, with those more keen in face-to-face contacts wanting to do more activities, and those interested in digital contacts wanting to make a new friend. So these findings have helped to develop an intervention called FONPA that we have been doing a trial on, where patients with psychosis were matched with one volunteer in the community with whom they could speak over the smartphone through audio, video calls, messages, and emails. And we offered participants a smartphone and monitored their communication and step count. As you can see, for example, an illustration of one of the participants' interactions. And we have used a sketch engine to analyze the written communication. And this is an online text analysis tool that works with large samples of language like SMS and emails. And you can see that most written words included things like good, hope, well, family, working, safe, God, sorry, thanks, and busy. And this intervention was quite positive to some of the patients, as this quote illustrates, saying that the phone call he had on Christmas is something that he will never forget, but also for volunteers who expressed a positive impact for their personal and professional lives, and in some cases even speaking when they were in different countries, overcoming long distances. So it has been said that AI will allow doctors to be more human, but we can also extend it and reflect whether technology is allowing humans to become more human. Interestingly, it has been predicted that by 2045, all advances in technology will outsmart all human beings. And this possibly may be giving rise to the increase of transhumans, which raises many questions. So, for example, would it be ethical to allow surgeons to replace someone's limbs just to outperform and run faster? Interesting questions for obviously important discussions. So all these matters are important to discuss. Who is accountable, why, and under which values? How autonomous will we be? What is the chain of decision making? How much privacy will there be? How much transparency will there be? What will be influencing our choices and decisions? Maybe in the future our cars will decide for us, this picture shows, but nevertheless it is important that humans continue to ensure that the purpose of the machine is in line with what we really want. So a number of research priorities for digital mental health were previously identified and published in the Lancet Psychiatry as a policy paper that you can check. And if you're interested in mental health but have not yet quite identified what research question excites you the most, I hope this gives you some source of inspiration. Thank you very much for your attention, and I leave you my contact in case you're interested in some of the aspects that I spoke, or if you want to be in contact. Thank you for your attention.